Hello, I'm Matthew Weinstock, Managing Editor for Modern Healthcare. Thanks for tuning in to the latest edition of the Checkup. The nation is facing yet another surge of COVID-19 cases, and public health experts fear that the holiday season will compound the problem with even more cases as family and friends have gathered first at Thanksgiving and now maybe with Hanukkah, Christmas, and New Year's coming up. The spike is putting a huge amount of stress on an already taxed workforce. We're hearing a lot about burnout. I'm joined today by Dr. Stephen Corwin. He's CEO of New York-Presbyterian Hospital in New York to talk about ways that leaders can help keep morale up and try to prevent staff burnout as we face this recent surge. Stephen, thanks so much for being with us today.
Thanks, Matt.
So before we talk really about staff and burnout and morale, tell me a little bit about your worries as leader of an organization and a doctor, public health expert. Dr. Anthony Fauci at the end of November worried that we're going to see a surge upon a surge following the travel for Thanksgiving. So we probably won't see those numbers for another week or so. But really, how worried are you about another spike?
Well, I'm very worried. I think that between pandemic fatigue, the whole issue on mask versus no mask, and the politicization of this, I think it becomes a problem. And then you saw many people traveling over the holiday, which I think adds to the potential burden. We're certainly seeing a significant uptick in cases in New York, and of course around the country we're now seeing it. So I think that until we get to mass vaccination, we're going to be struggling with this second wave or a wave across the country, to be honest with you.
And so you bring up COVID fatigue, masking, and the politicalization around that. We're headed into more of the holiday season. Are there things that health leaders can do to try to reinforce the necessity of social distancing and don't gather in large groups?
I think we just need to continue to be consistent about the message. I think we need to be consistent about the fact that there is a light at the end of the tunnel. That light at the end of the tunnel is the vaccine. And that as painful as this year has been, let's not make it more painful by losing more of our friends and loved ones towards the end of this year into early next year, right when the vaccine is around the corner. So I just think we've got to be continuing to emphasize that. And it doesn't help when public figures say one thing and then do another. It tends to breed mistrust in the system as a whole. And it certainly doesn't help that we've had a split in the country in terms of the severity of this crisis and what it means in terms of opening and closing businesses. But we can really see that if we just stick to it, I think that we'll be okay.
Okay. So let's pivot a little bit, talk about New York Presbyterian and particularly your staff. Tell me a little bit about what you're seeing in terms of just staffing levels. Are you able to keep adequate levels at this point? I know you've done some cross training to get people into the other departments. So walk us through a little bit of that.
Well, in the first wave of the pandemic, we clearly had all hands on deck. We were basically a system of 3,000 some odd beds, and we had 2,600 of those beds filled with COVID patients and 900 ICU beds filled with COVID patients with our normal ICU capacity of around 450. So it mandated shutting down all electives, anything but the most emergent cases and so on. This go round, I think that it appears to be substantially less. Currently, we're at about roughly 10% of where our peak was in the April timeframe. So we're able to do COVID care as well as other procedures. If it got substantially worse, we would have to throttle back on non-COVID care other than emergencies. We're certainly not at that point. The problem with staffing is twofold. Number one, if you get overwhelmed with COVID, you have to pull staff to manage the COVID care. And number two, with this now being across the rest of the country, the ability to draw resources from other parts of the country, staffing resources, is severely limited. So that's the concern around staffing, those two concerns.
Well, and on that draw front, you had the folks at Intermountain, Salt Lake, Utah, had sent people to New York early in the pandemic, and now I understand you've reciprocated, right? You've sent some people out that way.
We did, and we would have sent more if we weren't now experiencing our own surge. I think that what the Northeast experienced in April, now the rest of the country, the whole country is experiencing, and what the Southwest saw in the June-July timeframe, the whole country is experiencing. So I think staffing is stretched now across the country. You're certainly seeing that in rural hospitals. We're seeing people being overwhelmed in those rural counties, primarily because of the lack of ICU resources. Ultimately, you have to think about COVID as an inside-out problem. It starts with your ED and ICUs, and then it expands out. So field hospitals are great, but you really need the ICU level care. And certainly small rural hospitals can get overwhelmed by not having the ICU resources, either in personnel, equipment, beds, and so on.
And so does tele-ICU, it could get you so far. Can it really make up for that gap?
Partially. You have an expertise gap because of how complicated these patients are. It can partially be made up by the tele-ICU or the e-ICU concept, but you have to have staff in those ICUs, and you have to have beds, and that becomes a significant issue in very small rural access hospitals.
The collaboration you've seen with Intermountain, are you doing that with some rural hospitals in the New York State region, or do you see that collaboration being able to fold out beyond your work with Intermountain?
Well, I think that New York is a little bit different than other parts of the country, but not that different. I think that densely populated areas are going to continue to have problems. Multi-generational households are going to continue to have problems. Large gatherings create problems, and now we're just seeing that. And that, of course, going back to your first question, Matthew, is what everyone's concerned about over the Thanksgiving holiday. The fluidity of the travel, the still lack of sufficient testing resources and adequate testing resources, adequate reagents, et cetera. And that then leads to an overwhelming percentage of people getting infected, and then the inability to do contact tracing. You can't contact trace in the midst of a pandemic with high positivity levels. It also hurts your ability to do testing, because with low positivity, you can do pooling of testing. The higher the positivity rate, the less you can do pooling. So it puts stress on the whole testing regimen. I think everybody now is seeing it, rural, urban, and likewise. We're fortunate as a large academic center to be able to shift resources amongst our hospitals, to be able to have the personnel expertise. So we're better off than most, admittedly so, but it's still going to be a slog.
Sure. As you think about your staff, I know at the beginning of the pandemic, I believe you were doing regular check-ins or video updates with the staff. What are you doing now that we're into this? We call it a second surge. I don't know that we ever finished the first surge, quite honestly, but so what are you doing just to try to keep people's morale up and impact that burnout that we are seeing anecdotally? There's no real data yet, but we certainly are hearing it anecdotally.
I think there are a couple of things. First, I think we are continuing to update our staff and continuing to virtually round with every nook and cranny in our system, so that people see the presence of leadership and that we can move forward together as a group and have that sort of sense of unity. We're all in it together. I think also you have to offer the mental health resources to your employees and continue to emphasize that asking for help is exactly what you should do, not shouldn't do. And then I think we have the third thing, which is what I would call a light at the end of the tunnel. Look, We can see that these vaccines are effective. It looks like they're extremely safe. We can get through this together. I know no one wants to go through this again. I know no one wants to sort of see the suffering that they saw the first go round or what we've seen in the country. But let's try to climb this last hill. And I think that people resonate to that. To say that the number of times I've had employees tell me across all walks of life, nurses, doctors, environmental service workers, laboratory technicians, say, I don't want to have to go through this again. It's heartbreaking because you realize how much we asked our healthcare workers to do the first go round, or in a continuing way, and it wears on people. There's just no two ways around it, and I think we got to be as cognizant as we can of it. We encouraged all of our employees in our lull, which was in the summertime and early fall, to take vacation time, to spend time with their families, because we said we're going to have to gear up for this getting worse in the fall, and it has gotten worse. So I don't think there's any magic bullet here. I think truth telling, talking to your staff, recognizing that some people handle it better than others, encouraging people to take advantage of mental health services, which we've made widely available at no cost. Those are important things.
Have you seen an uptick in the use of the mental health services that you're offering staff?
We try not to track it because we do not want to create a stigma associated with it.
Sure.
So we really created a firewall. I have no idea who's accessed it. I have no idea whether it's a doctor, a nurse, et cetera. And we made sure that our employees knew that this was completely anonymized. And I think that's really important because no one wants to be stigmatized with this.
Right. I'm curious too, Stephen, we focus so much, and modern healthcare, is guilty of this. We focus so much on the doctors and nurses, but obviously there are folks, the lab techs you mentioned, the allied professionals, the folks who come in and clean the rooms when someone leaves. Is there a different set of protocols or staffing things you need to put in place for those folks who are also dealing with this?
Well, I think the important thing for all of us is to recognize that these are hospitals are intricate timepieces. You need every aspect of a hospital to work effectively, whether it's environmental services, laboratory technicians, pharmacy technicians, pharmacists. I think everyone got a strong dose of reality this first go round, including things that are that no one ever thinks about. Morgues being overwhelmed, all of those types of things where you see people going to great lengths to make sure that they're providing the safest care. And that's why it's important for us as healthcare professionals to say, look, when this vaccine comes, everyone's going to get vaccinated. And if you're in the emergency department as a social worker or a clerk registrar or as a security officer, you're going to be first in line with the doctors and the nurses. We're not discriminating as to which class of healthcare workers gets preference. Hopefully we'll have enough vaccine to go around. I think that the latest that we've heard is we should be able to do the vast majority of frontline healthcare workers in that first or second tranche. And we're hoping that that's the case.
Will you mandate vaccination for your whole staff?
We're inclined to do that, yes.
Yeah. How and when do you make that decision?
We'll make that decision once we see how much of the vaccine we get first. I think that if there's less vaccine than there is demand, then it's less incumbent upon us than if there's more vaccine than there is demand. But I look at it as I'll be the first person to get in line for a vaccine. I know that there has been some concern about the safety profile. I think we've got to rely on the scientific evidence on the safety profile. But yes, I would be inclined to mandate it because we don't want our healthcare workers to get sick, and we don't want our healthcare workers to infect each other, which can happen, or infect patients, which can happen. And I think that's critically important to do. Now, of course, it's not been proven to be, as whether it's safe in women that are pregnant. They can be excluded. It's not been proven yet to be effective or safe in children, not that we employ children. And certainly if you had an antecedent religious objection to it, or you had a condition that was such that you couldn't possibly get the vaccine, we would exclude the usual exclusions. But short of that, no, I think it would be unfair to the public, to be honest with you.
Right, sure. Beyond your staff, what role do you see New York Presbyterian playing once there is more mass availability to a vaccine?
Well, we'll do whatever is required of us by the state and the federal government. We want to be as altruistic as possible. I think the likelihood is that we'll be asked to supply personnel to help with the mass vaccination, which of course we would do. I'm sure that the state can decide mass vaccination sites. I don't think that will be an issue. I think it'll be a personnel issue. And then as far as I'm concerned, it's all hands on deck. Because if in fact the efficacy of the Moderna and the Pfizer vaccines are what we think, and the safety profile is what we think, then the only way the country really gets to the other side is to get to mass vaccination. We would certainly participate in education. We would certainly participate, especially with underserved communities, in educating them so that they do not feel that they're being experimented upon. There are language issues which you have to overcome. So we have tremendous banks of translator services that we use. So we would put everything that we have available to the state to make sure that it happens.
Yeah, there's a lot more than just rolling out, go to your CVS or Walgreens and get a shot, right? The language barrier, the distrust that communities have. And then obviously, the anti-vax movement, which has been well documented already too.
Yeah, I mean, I don't think it helps. And we're just going to have to try to overcome that as a country. We've been, I think, down the road of science denial, and part of that is probably something that we have to be examining ourselves. Why does the public not trust science as much as they used to? And part of it may be the language that's used. Part of it may be that it's phrased in such a way where people think they're being looked down upon and that their views are not taken into account. So we have to do as much self-examination as opposed to just saying, well, these people just are, cave dwellers.
Right. No, that's an interesting point. Stephen, we're wrapped up our time here. There's much more we could certainly talk about, and we'd love to be able to check back in with you, as things are allowed, see how your winter and into January goes. Love to be able to stay in touch.
Thank you, Matthew. Really appreciate you. Stay safe and stay well.
Thanks, you too. And I'm Matthew Weinstock with Modern Healthcare. Be sure to come back next Monday for another edition of The Checkup.